Assalamu alaikum. Good afternoon. Hello, everyone.
Assalamu alaikum.
السلام عليكم دكتور.
I hope you all are doing well, and I'm really happy to have you with me today in this free webinar. Today, inshallah, we are discussing the anatomy of the anterior abdominal wall, one of the important topics related to the very important subject, anatomy. And let's go through a quick journey to explore the important landmarks in the anterior abdominal wall. First, I know that today we have some of our course candidates and other colleagues from the free groups as well. So I'm really glad to have all of you today in this webinar. So, of course, the anterior abdominal wall part is important not only for the exam, as we know, it's one of the important points regarding our practice because we do the surgeries, and of course, we should know the anatomy of the anterior abdominal wall to be familiar with the anatomy of this part when we do our surgeries, whether we do the cesarean section or the gynecological surgery. So, of course, it's important as a surgeon to be familiar with the anatomy of the field we are dealing with. So, simply speaking, that the anterior abdominal wall is layers of skin, fascia, muscles, then the extraperitoneal fascia and parietal peritoneum. The anterior abdominal wall is bounded superiorly by the thoracic cage, and then below the thoracic cage, we have these important muscles that we are going to discuss some points about, which are the rectus abdominis muscles, the external internal oblique muscles, and the transversus abdominal muscles and fascia. So these are the layers of the anterior abdominal wall. So we have skin, superficial and deep fascia, muscles, and the extraperitoneal fascia and parietal peritoneum. Of course, the skin of our body has natural line of cleavages. And in the anterior abdominal wall, as we see in the figure, these skin lines run horizontally around the trunk. So when we do incisions in a transverse way like this gives a better healing and narrower scar. So it's a better cosmetic scars rather than doing midline scars, okay? Because the horizontal one runs with the cleavage line, so the healing will be better. Cosmetically, of course, will be better during healing. But of course, when we do the midline scars, this gives wider scar. It's not cosmetically looks good like the horizontal or the transverse scars. And of course, I have another session or a webinar about the abdominal incisions and nerve injuries during gynecological surgeries. It's also found on our YouTube channel if you want to get a look on this part about this clinical point. Of course, here I'm talking about the skin. Still, we are talking about the superficial layers, and here I'm talking about the cutaneous nerve supply. The cutaneous nerve supply is derived from the lower 6 thoracic and first lumbar nerves. The lower 6 thoracic and the first lumbar nerves. So the thoracic part are the lower 5 intercostal. We say that these are the lower 5 intercostal, and the subcostal, which is T12. The subcostal is T12. So we are talking about T7 to T11. These are 5, and the subcostal T12. So they are 6 thoracic nerves. And the first lumbar, okay, by the iliohypogastric and ilioinguinal nerves. Of course, we know that iliohypogastric itself has also a sharing by T12, okay? Like the origin of iliohypogastric is T12 and L1, okay? So L1 lumbar nerve is represented by two nerves, iliohypogastric and ilioinguinal. The nerves of the anterior abdominal wall skin or the nerves of the anterior abdominal wall supply not only the skin, supply the skin, the muscles, and also the parietal peritoneum. So when we have an inflammation in the peritoneum, if the patient is having, peritonitis, for example, okay, this is reflected on the skin and the muscles. That's why patients who have peritonitis, they have rigid abdomen, okay, and they have increased tone of the abdominal musculature and a pain in the overlying skin. Okay, so also that's an explanation of why the people who have peritonitis looks or feel the pain in the skin and in the muscles, they have tone and rigidity in their abdomen. Regarding the cutaneous blood supply, the blood supply of the superficial parts of the anterior abdominal wall, we can say simply that the skin which is near the midline, is supplied by branches of the superior epigastric artery. Most of them are branches of the superior epigastric artery, which is actually a branch of the internal thoracic artery. And also, it gets a blood supply from the inferior epigastric artery, which is a branch of the external iliac artery, which is a branch of the external iliac artery. So this is the external iliac, okay? And this is the inferior epigastric. So the inferior epigastric is a branch from the external iliac, and the superior epigastric is a branch of the internal thoracic artery. The skin on the lateral side, or we say it's the skin of the flanks, okay, they get blood supply from the intercostal, lumbar, and deep circumflex iliac artery, or the circumflex iliac arteries in general. We have the superficial, and we have the deep circumflex iliac arteries, and we have the intercostal, and as well as the lumbar arteries. The inferior epigastric artery arise from the external iliac artery, which is happening. This is occurring superior, just superior to the inguinal ligament, and we are going to talk about the inguinal ligament in a while. And above the umbilicus, there is anastomosis between the superior and inferior epigastric arteries. Also, the inferior epigastric makes anastomosis with the posterior intercostal arteries, which supply the flanks. So we have two anastomoses here, one between the inferior epigastric and superior epigastric, and one between the inferior epigastric and the intercostal arteries, which makes anastomosis also as well with the inferior epigastric here. So this is the cutaneous blood supply. Also, the superior and inferior epigastric arteries, they both perforate the recti muscles, the rectus abdominis muscle, to supply the muscle itself and continue until reaching the anterior wall of the rectus sheath to supply the skin of the abdomen. So they arise deeply, okay? Then they perforate the muscles until reaching the skin. They perforate the recti muscles and supply them, then reach the anterior wall of the rectus sheath to supply the skin of the abdomen, okay? And the inferior epigastric vein drains into the external iliac vein just above the inguinal ligament. So it's corresponding to the artery. We say the inferior epigastric artery is a branch of the external iliac artery. So also the vein is corresponding to the artery. The vein is draining into the external iliac vein just above the inguinal ligament. One of the important clinical implications, especially during laparoscopy, is the landmark of the inferior epigastric vessels. The passage of the inferior epigastric vessels underneath or beneath the anterior abdominal wall, it raises a fold of peritoneum, as we can see here. Okay, in this graph, we have lateral umbilical folds. One is here, okay, and another one is here. This is a landmark of the what we say we call them the lateral umbilical ligaments on the deep surface of the anterior abdominal wall. And this is very important during surgery. And here I'm talking about during the making the laparoscopy. So imagining that now we are inside the abdomen. This is the camera of the laparoscopy, okay, and we are looking at the inside of the peritoneal cavity, and we should recognize these umbilical ligaments. Why? Because when we insert the lateral ports of the laparoscopy, when we insert the ports where we are going to insert the tools that we are going or the instruments which we are going to use in the surgery, okay, we should avoid injuring this vessel because this injury will result in a major hemorrhage, okay? So we should identify the medial umbilical ligaments, okay, and then this is the lateral umbilical ligaments, and we have to avoid the lateral umbilical ligaments because they will result in injury of the inferior epigastric artery during the lateral ports or the side ports of the laparoscopy, okay. Also in cesarean section, if you do, a wide skin incision and wide sheath incision, you might injure the inferior epigastric vessels. This is also very risky because if you don't secure the hemostasis of these vessels, this might result in what we call rectus sheath hematoma. Rectus sheath hematoma. So, of course, when you do a transverse phalangeal incision, okay, you have to avoid the injuring the inferior epigastric vessels, especially when you do the transverse incision in the rectus sheath, okay? But if you feel that you made an injury in the vessel, you have to make sure before closing the abdomen that it's completely secured, because if you leave it without complete secure or securing or hemostasis, after the surgery, when the blood pressure start to rise slightly, okay, because we know during anesthesia the blood pressure may be slightly low, okay, especially during the spinal anesthesia, but when the patient recover, the blood pressure sometimes rise and small injuries of the blood vessels start to ooze blood, okay. This might result in what we call subsheathal hematoma or rectus sheath hematoma, and this is very problematic, of course, because it may result in anemia, hypertension, and even infection later on. So it should be dealt with during the surgery better than having this complication post-operative. Regarding the venous drainage, okay, we have networks of veins around the umbilicus. Usually above the umbilicus, the drainage is usually to the lateral thoracic vein, then to the axillary vein. Okay, so the end venous drainage will be axillary vein, and this is through the lateral thoracic vein. Below the umbilicus, we will find that the venous drainage, it will be through the superficial epigastric and great saphenous veins ending into the femoral vein. Also, we have some para-umbilical veins which make anastomosis with the portal veins, which we call portal systemic venous anastomosis. Portal systemic venous anastomosis. That's why in cases who are hepatic and having portal vein obstruction, we will find this clinical. I think all of you know the caput medusa, this clinical sign, the dilatation or the tortuosity of the para-umbilical veins, because the blood is distending these veins because of the portal vein obstruction, because there is anastomosis here between the systemic veins and the portal veins, and because that the portal vein is obstructed, this will lead to a distension of the veins with the blood. Here and this picture, we call it caput medusa. This occurs in hepatic patients, especially if they are in a case of liver cirrhosis. Am I clear so far, everyone? Okay, that's great. So regarding the lymphatic drainage, and still we are talking about the superficial layers, okay, we still didn't go through the muscles and other landmarks. So regarding the lymphatic drainage, above the umbilicus also, most of the lymphatic drainage go to the axillary lymph nodes, while below the umbilicus, we will find that it goes to the superficial inguinal lymph nodes, superficial inguinal lymph nodes. And of course, sometimes people who have a swelling in the groin, this may be due to enlarged inguinal lymph nodes. So maybe this is an inflammatory, okay, swelling, maybe due to metastasis by a certain tumor. So swelling in a groin might be due to the enlargement of the superficial inguinal lymph nodes. Okay. After the skin, of course, and subcutaneous layer, we have these fascia, okay? And the fascia, okay, we have superficial fascia and deep fascia. The deep fascia simply, it's the fascia connecting or sorry, covering the muscles, and it lies immediately deep to the superficial fascia. So no more information we have about the deep fascia. The only information we might need to know is about the superficial fascia because they have some names. We need to remember these names, okay? The superficial fascia has two layers, superficial fatty layer itself and deep membranous layer. The superficial fatty layer, we call it fascia of Camper, and the deep membranous is called scarbus fascia. So the superficial fascia itself has two layers, superficial, and this is fatty layer, and deep, which is a membranous layer. The superficial is a fatty, I said, and deep is membranous. The fatty one, we call it camper, and the membranous, we call it scarbus fascia. The membranous layer, which is the deep layer or the scarbus fascia, will continue until the lower limb to be completing as or fusing with the deep fascia of the thigh. We call it fascia lata. So it will continue inferiorly as the deep fascia of the thigh, fascia lata. And this is in the lower limb, while in the pelvis, it will continue as the collis fascia in the perineum. So this fascia, if this is the abdomen, okay, this is the deep membranous layer or the scarbus fascia, and this is the abdomen, okay. Regarding the lower limbs, it will continue as fascia lata. And regarding the perineum, it will continue here as what we call the Colles fascia. Okay, so if this is a fascia itself, it will continue here as the Colles fascia of the perineum, and here it will continue as the deep fascia of the thigh or fascia lata. Now let's talk about the muscles. The muscles, we have one midline muscle vertically situated, which is the rectus abdominis muscles, two recti muscles, okay? And laterally from exterior to interior or from outside to inside, we have the external oblique muscles, internal oblique, and transversus abdominis muscle. Let's look here. This is the recti muscles in the midline. Okay. And of course, we have three muscles from outside to inside. This is the external oblique. And here there is a cut section here. We removed the external oblique, so the internal oblique will appear. Then when we remove the internal oblique, the transversus abdominis muscle will appear. The first muscle we have is the external oblique muscle, the external oblique muscle. This muscle originating from the outer surface of the lower eight ribs, this is interdigitating or overlapping with fibers from other muscles they are called the serratus anterior and latissimus dorsi muscles, okay? And this muscle is inserted into the xiphoid process, then the linea alba, then the pubic tubercle in the pubic bone, and the iliac crest. So it's inserted here, xiphoid process, linea alba, pubic tubercle, and the iliac crest. And this muscle is innervated by T7 to T11, lower 5 intercostal, and the subcostal nerve. The subcostal nerve. The lower fibers of this muscle, or the aponeurosis of this muscle, external oblique, is stretching between the anterior superior iliac spine to the pubic tubercle. This is the lower fibers of this muscle. Okay, this is stretching from here, from the anterior superior iliac spine. This is this white line, okay, until the pubic tubercle. This is the lower fibers of this muscle. We call it the aponeurosis of the muscle. And folded on itself, okay, to make what we call the inguinal ligament. It's like this, okay? It's look like this. Okay, it's like making a folding, okay, on itself. So it's like having a groove, okay, a floor like this, or a groove, which is the inguinal ligament, okay, because there is a folding upwards like this. So it has like a groove, okay, or a floor like this. This is called the inguinal ligament. So it's not a straight line like this. No, it has something like a groove inside because the aponeurosis is folded on itself. This form the floor of the inguinal canal. This folding makes the floor of the inguinal canal. Okay, this is the stretching of the inguinal ligament. So it's coming from, this is the anterior superior iliac spine, and to the pubic tubercle, we call that the inguinal ligament. Here, from the medial side here of, or the medial end of the inguinal ligament near the pubic tubercle here, okay, this is the pubic tubercle, which I'm coloring by red here, okay. This is the medial end of the inguinal ligament. If you can notice here, there is a fibers backwards like this, okay, here. These are fibers from the ligament passing backwards towards the pectineal line. Pectineal line here is the bone structure here in the hip bone, okay? So the fibers of the inguinal ligament will go backward like this to make another ligament. We call it the lacunar ligament, to make the lacunar ligament. This is the lacunar ligament, which is making the medial boundary of this ring, okay? This ring here, we call it the femoral ring, the femoral ring. And I'm going to explain more about this lacunar ligament and the femoral ring in a while, okay? But I'm just telling you that the inguinal ligament, when reaching the pubic tubercle, it's folded back on itself again like this, or folded backward to the pectineal line to make this arch, okay, which is called the lacunar ligament, which makes the medial boundary of this opening, which we call it the femoral ring, the femoral ring. So this is another picture here about the inguinal ligament. It stretches between the anterior superior iliac spine to the pubic tubercle. Okay, it's obliquely placed between the the anterior superior iliac spine and the pubic tubercle. And as we can see here, the groove of this ligament, or the ligament itself, make the floor of the canal, which we call the inguinal canal, which is situated obliquely between the deep inguinal ring and superficial inguinal ring. And this canal in female transmit the round ligament of the uterus to be inserted into the labia majora and also the ilioinguinal nerve, the ilioinguinal nerve. And this canal, as we can see here, is located just superior to the medial half of the inguinal ligament. It's not covering the entire length of the ligament. No, it's just lying above or superior to the medial half of the inguinal ligament. This is another picture, okay, showing that's the deep inguinal ring, and that's the superficial inguinal ring. And we can see that the round ligament is moving through the here, which is in the yellow color or this brown color. This is the round ligament to be inserted into the labia majora. Okay. So what are the boundaries of the inguinal canal? What are the boundaries of the inguinal canal? The floor of the canal, as I mentioned, it's formed by the enfolded inguinal ligament. The enfolded inguinal ligament, this is the inguinal ligament here, okay? This is the floor of the inguinal canal. And also it's blended or uniting with the transversalis fascia, with the fascia transversalis, okay? The roof, as we can see, this is the roof. These arching fibers of the transversus abdominis muscle, okay, and the internal oblique muscle. Both of them are inserting here medially, and the uniting or the meeting between the fibers of the internal oblique muscles and the transversus abdominis muscle make a tendon here. We call it the conjoined tendon or the falx inguinalis. Okay, this is another tendon called the conjoined tendon, which is the meeting of the fibers of the internal oblique muscles and the transversus abdominis muscle. And the arching of the fibers of transversus abdominis and the insertion of the internal oblique, both of them make the flow, make the roof of the canal. So this is the floor of the canal here. Okay, which is the inguinal ligament, and this is the roof of the canal, which are the arching fibers of the internal oblique and transversus abdominis muscle. The anterior wall of the canal, okay, this is another figure about the canal, okay, like we are looking from anteriorly to posteriorly. The anterior wall is formed, of course, of skin, fascia, and the aponeurosis of the external oblique muscles. The aponeurosis of the external oblique muscles. These are the anterior wall of the canal. Also, on the lateral part, of the anterior wall, we have reinforcement by the internal oblique muscles to be lying directly in front of the deep inguinal ring to make a reinforcement for the deep inguinal ring. Okay, so anteriorly, we have the external oblique aponeurosis, and laterally, we have also a reinforcement by the internal oblique muscle. Posteriorly, we have the transversalis fascia, and it's medially reinforced by the conjoined tendon to be also lying in front of the superficial inguinal ring to make more support of this ring. And this picture is, showing a better, imagination of what I'm mentioning. Like if I'm looking from above now, okay, this is the deep inguinal ring. This is the deep inguinal ring, okay? And this is the superficial inguinal ring. As we can see, the canal anteriorly is bounded by the skin and the aponeurosis of the external oblique. And also we have a reinforcement laterally by the internal oblique. This reinforcement will be just opposite to the deep inguinal ring. So this reinforcement will help, to make more power for this ring, okay, to avoid herniation of any content. When we talk about posteriorly we have, of course, parietal peritoneum, the fascia transversalis. This is the posterior wall of the canal, and reinforced medially by the conjoint tendon and reflected part of inguinal ligament, a reflected part of the inguinal ligament. So this is also a reinforcement for the superficial inguinal ring. Clear? Clear, everyone?
Yes, sir.
Yes.
Okay. So this is the deep inguinal ring, as I mentioned before, and this is the superficial inguinal ring. The deep inguinal ring is formed in the transversalis fascia, okay? And anatomically, it lies midway between the anterior superior iliac spine and the symphysis pubis. This is the deep inguinal ring. If you want to locate it as a surface anatomy on the anterior abdominal wall, it will be midway between the anterior superior iliac spine and the symphysis pubis. And the transversus abdominis fibers arch over it superiorly like this, and the inferior epigastric vessels are an immediate medial relation. You will find that the inferior epigastric vessels lies as an immediate medial relation to this deep inguinal ring. As I told you, we have here lateral enforcement of the internal oblique muscle. So when the intra-abdominal pressure is raised, the contraction of the internal oblique fibers is increased, so they act as a valve mechanism to the deep inguinal ring, closing it down to avoid herniation of any abdominal content through the ring. The superficial inguinal ring is just above the inguinal ligament and lateral to the pubic tubercle, lateral to the pubic tubercle. And it's an opening in the aponeurosis of the external oblique muscle. The margins of this ring is thickened. I mean that the aponeurosis of the external oblique muscle is thickened around this ring to form what we call the lateral and the medial crura of the ring, the lateral and the medial crura of the ring. So we have a lateral crus and a medial crus for the superficial inguinal ring. This this is will give you a better, look for this crura. Okay, here, look at this graph. If this is the superficial inguinal ring, okay, an opening to the inguinal canal, this is a medial crus here, which I'm showing by the arrow here, the folding of or the thickened part of the aponeurosis here, and we have here a lateral crus. It's like, the two gates to the opening here. Okay, medial crus and lateral crus. Of course, as I told you before, the conjoint tendon and the reflected part of the inguinal canal, strengthen the weak part of the abdominal wall caused by the canal, and strengthen the superficial inguinal ring. Also, the oblique orientation of the canal, okay, because it's not in a straight direction, no, it's in an oblique direction in the inguinal region. This makes more strengthening of the canal to avoid herniation through the inguinal canal to form what we know as the inguinal hernia. This also the picture here. Let's now show some landmarks. This is the aponeurosis of the external oblique, okay? And as I told you, it's enfolded backwards on itself to form the inguinal ligament. This is the inguinal ligament here, which I'm marking by the red color. Okay? This is the superficial inguinal ring, and this is the medial crus, sorry, the lateral crus, and this is the medial crus. As we can see here, the inguinal ligament is reflected backward like this to form the lacunar ligament. The lacunar ligament, which is the medial boundary of the femoral ring. And the femoral ring is an opening to what we know as the femoral canal. And I'm going to explain it in a while. Okay. These are some important landmarks we have to put in our mind. This is the opening. Of course, the opening is not obvious superficially. It's a deep opening, but it's just, I'm marking the location of the deep inguinal ring, which is, as I told you, midway between the anterior superior iliac spine here and the symphysis pubis. So if you want to mark or make a marking as a surface anatomy, measure the length between the anterior superior iliac spine and the symphysis pubis, take a point midway between them. This will be the location of the deep inguinal ring. Hope this picture makes things clearer, everyone. Am I clear so far?
Yes, sir.
This is the location of the deep inguinal ring, okay, which is marked in the diagram actually by the light blue color, but I put this red color, okay? Of course, it's deep ring, so it should not be found superficially. This opening is from inside. But if I want to locate it, okay, at the surface anatomy, when I make a palpation to the abdomen, for example, and I ask you, locate the site of the deep inguinal ring, all you have to do is to palpate the anterior superior iliac spine and make a line between this anterior superior iliac spine, okay, here, to the symphysis pubis, and take a point midway. This will be the location of the deep inguinal ring. It's midway between the anterior superior iliac spine and the symphysis pubis. We said the canal is not taking the entire length of the ring. No, the canal is just above the medial part of the inguinal here. This is the canal, okay? This is another picture, okay? This is the external oblique aponeurosis. This is the inguinal ligament. As you can see, this is the superficial inguinal ring. So we say this is the medial crus, and this is the lateral crus of the ring. And this is what we call the reflected part of the inguinal ligament, which makes strength to the superficial inguinal ring. Okay, so we said we have what we call the lacunar ligament, okay, and it's make the medial boundary of the femoral ring and so on. So we have an anatomical landmark in the lower part of the abdomen, or we can make it more accurate. It's in the superior or the supromedial part of the anterior thigh. This is called the femoral triangle. This is the femoral triangle. The femoral triangle is bounded superiorly by the inguinal ligament, okay? Medially by this muscle, we call it the adductor longus muscle, and laterally by muscle called sartorius muscle. And the floor of the ring, the triangle, is made by muscles, the adductor longus, a continuation of the adductor longus, and other muscles, iliacus, psoas major, and pectineus muscles. And the roof of the triangle is made by the fascia lata, and which is the deep fascia of the thigh, and the cribriform fascia at what we call the saphenous opening. Here we have an opening called the saphenous opening, and it's covered by a fascia called the cribriform fascia. I will show you another picture here. This will make the imagination better, okay? So this is the triangle. Anteriorly, superiorly, we have the inguinal ligament as marked here. This is the inguinal ligament, okay? Laterally or medially, sorry, we have the adductor longus muscle, and we have here the sartorius muscle. Three of them make the triangle, okay? And then the floor of the floor, or from inside of the triangle, we have the muscles adductor longus, iliacus, psoas major, and pectineus. Of course, it's difficult to show them on a picture now, but just know the names of the muscles. But the roof of the triangle, this is the roof of the triangle, okay? You can see here, we have the fascia lata, okay? Which is marked here, which is, this one shadowed by the blue color. Okay, this is the fascia lata. There is a defect in the fascia lata here, transmitting the great saphenous vein. Okay, this is a defect in the fascia lata to transmit the great saphenous vein from the femoral vein. This is the femoral vein, which is in the blue color. This is in the femoral artery, and this is the femoral nerve. Okay, as we can see from the femoral vein, we have the great saphenous vein. So this great saphenous vein is transmitted through a defect in the fascia lata. We call it the saphenous opening. And this saphenous opening, okay, is covered by another thin fascial layer. We call it the cribriform fascia. The cribriform fascia. May you make sure that your mics are closed, please? Dr. Mahreen Jalal, I think your mic is always open. So please, this cause some, side noise. Okay, so this is the saphenous opening, okay? And this saphenous opening, also we call it fossa ovalis. This is another name of this opening. It has two names, fossa ovalis or the saphenous opening, which transmit the great saphenous vein from the femoral vein here, or draining into the femoral vein, I mean. And it's covered, this defect in the fascia lata is covered by another thin fascia. We call it the cribriform fascia. Is this part clear, everyone? Mm. Okay. So what are the contents of the femoral triangle? The content of the femoral triangle are, we call it navel, from lateral to medial. From lateral to medial, we have the nerve, we have the artery, we have the vein, okay, and we have the canal. Okay, we call it E because it's actually an empty space, just containing lymph nodes, okay, and lymphatics. These are the contents of the femoral triangle from lateral to medial. When we want to talk about the main things, the nerve, artery, and vein, so they are nav from lateral to medial, or van from medial to lateral. The femoral vessels and the femoral canal are enclosed in what we call the femoral sheath. If you look at the green shadow here, we have a funnel-shaped sheath like this, enclosing the ring, the artery, and the vein. We call it the femoral sheath, while the nerve lies outside this sheath. Look back at this picture. As we can see, the nerve is outside the sheath. This is the sheath, okay? Okay, and enclosing the ring, the artery, and the vein. But the nerve is outside the femoral sheath. Look, this is another picture also to show you that this is the femoral sheath. It's a funnel-shaped sheath like this, which has an outer wide part, then it's going in a funnel shape like this. This is a sheath, okay? It's enclosing the vein and the artery. And here we have the femoral canal containing the lymph node of Cloquet, or the Rosenmiller lymph node. This is the femoral ring, which is the opening of the femoral canal. It's the superior opening of the canal, which is colored by this yellow color here. This is the femoral ring. This is the lacunar ligament, which is in orange color, and this is the femoral vein. This is an oval shape opening, and its transverse diameter is about 1.25 centimeter. 1.25 centimeter. The femoral ring is bound anteriorly. Here we have reversed the picture. So this is the canal here, or the femoral ring here. This is the vein, this is the artery, and this is the femoral nerve, okay? This is the ring. The ring is bounded anteriorly by the inguinal ligament and posteriorly by the pectineal or the Cooper ligament. Medially, it's bounded by the lacunar ligament, and laterally it's separated from the vein by a very thin septum. And as I told you, the canal just contains some lymph nodes, and the major one, or the largest one, we call it the lymph node of Cloquet. The clinical application or implication here, that this femoral ring is a weak point in the abdominal wall, especially in women than in men, because it's wider in women. And this can allow herniation of some intestinal content through the femoral ring, okay? The problem is that this intestinal loop might be strangulated or obstructed by the lacunar ligament. This is another problem. Not only hernia, but maybe strangulated hernia, which lead to ischemia of this loop of Powell, okay, and necrosis of this loop of Powell. So, of course, this kind of hernias must be dealt surgically, and don't wait, or the surgeon, of course, this is not our specialty, but the general surgeons don't prefer to wait, because if there is a loop of intestine here, it might be strangulated by or obstructed by the lacunar ligament. So this is what about the inguinal ligament, inguinal canal, femoral triangle, the saphenous opening, the femoral ring, and these important landmarks. Let's continue with the muscles, okay? We have the internal oblique muscles. This muscle originates from the lumbar fascia, which is the fascia of the posterior muscles of the spine here. We call it the lumbar fascia. It also originates from the lateral two-thirds of the inguinal ligament, and from the anterior part of the iliac crest. So from the lumbar fascia, from the iliac crest, and from the inguinal ligament, to be inserted into the lower three ribs and costal cartilage, xiphoid process, linea alba, symphysis pubis, and the pubic crest. So it arises from the lumbar fascia, anterior superior, iliac crest, and inguinal ligament to be inserted in the lower three ribs, xiphoid process, linea alba, pubic tubercle, pubic crest, and the pectineal line. It's also supplied like the external oblique by the lower six thoracic nerves and ilio, like T7 to T12, so lower five intercostal, subcostal as well, and also get a nerve supply from the iliohypogastric and ilioinguinal nerves. The importance of the internal oblique muscle, that it has an aponeurosis which share importantly in the rectus sheath, the sheath which is covering the recti muscles. This is the rectus muscle, okay, in the midline, and laterally we have three muscles: the external oblique muscle, internal oblique muscle, and transversus abdominis muscle. Here, okay? So this is the rectus muscle, which is in red color here, okay? We have the external oblique muscles, internal oblique muscles, and transversus abdominis muscle. Each muscle has an aponeurosis. Each muscle has an aponeurosis. The main part of the rectus sheath, okay, is made by anteriorly by, if you can see here, the external oblique muscle give an anterior part of the rectus sheath. Then the internal oblique aponeurosis will split into two parts. One will pass anteriorly and one will pass posteriorly. Then the transversus abdominis aponeurosis will share in the posterior wall of the rectus sheath. So we can say the main part of the rectus sheath anteriorly is made by the external oblique aponeurosis with the anterior lamina of the internal oblique aponeurosis, and posteriorly it's formed by the posterior lamina of the internal oblique aponeurosis with the transversus abdominis aponeurosis. This is the main part of the rectus sheath. But of course, the rectus sheath, it's not the same on the entire abdominal wall, okay? This splitting occurs below the costal margin, of course, not at the costal margin, below the costal margin, at a point midway between the symphysis pubis, okay, and the umbilicus, a point midway between the symphysis pubis and the umbilicus. So this splitting occurs from a point below the costal cartilage until a point midway between the umbilicus and the symphysis pubis. Because below this point, as we can see in the below picture here, the aponeurosis of the three muscles, all of them pass over the rectus muscle, and the rectus sheath posteriorly is just made by the transversalis fascia, which is in the blue color here. Dr. Muniba is asking, for exam purpose, it's essential to memorize the origin and insertion of the muscles? No. I haven't seen any question asking about the origin and insertion. That's why I just read them quickly. But of course, it's an important information for us to know, for practice, I mean. For exam purpose, no. But it's important to know the nerve supply. The nerve supply is very important to know for each muscles. Because as you can see, most of the anterior abdominal muscles has multiple origins and multiple insertions. So it's difficult to have this in the exam, okay? I haven't seen any question before in the exam regarding the origin and insertion. Okay, this picture will give you another, imagination about how the sheath is different. I mean, here, this is the recti muscle, okay? From above to below. The muscle should be covered by the rectus sheath from posteriorly and anteriorly. This is anteriorly, okay, and this is posterior. But look here. We have three parts of this sheath. But at the costal cartilage here, we have only the anterior rectus sheath wall made of the external oblique aponeurosis, and posteriorly only costal cartilage. There is no posterior rectus sheath wall here, okay? Then below the costal cartilage, then we have this splitting, posterior rectus sheath wall and anterior rectus sheath wall. Posteriorly made, as I told you, by the transversus abdominis aponeurosis with the posterior lamina of the internal oblique. Anteriorly made by the external oblique aponeurosis and the anterior lamina of internal oblique. Then below this point here is midway between the umbilicus and the symphysis pubis. The aponeurosis of all three muscles will pass anteriorly. So the rectus sheath is just made by aponeurosis anteriorly and posteriorly by this blue color, which is the fascia transversalis. This crossing of the aponeurosis, okay, and the line which marks the end of this splitting and movement of all aponeurosis from posteriorly to anteriorly, we call it the arcuate line. The arcuate line. It's midway between the umbilicus and the symphysis pubis, or it marks the end of this splitting of the rectus sheath. This also arcuate line, as we can see anatomically, it presents where the inferior epigastric artery gain access to be enclosed in the rectus sheath. Am I clear so far, everyone? I have 43 participants today. Where are you guys? Okay. I will take these 3 replies as representatives of the other 42 participants, okay? So we have also another tendon I gave you an idea about is the conjoint tendon or the falx inguinalis, okay? This is the meeting of the fibers of the internal oblique muscles, which is inserting into the pubic crest and the medial part of the pectineal line together with similar fibers from the transversus abdominis muscle. This is the transversus abdominis muscle here, okay? And this is the internal oblique. This muscle and this muscle. As we can see, they meet here at the pubic crest and the pectineal line. The fibers or the meeting fibers of them both together makes the conjoint tendon or the falx inguinalis, which lies, as I told you, behind the superficial inguinal ring to strengthen this point in the abdominal wall, and medially it's continuous with the anterior wall of the rectus sheath. So it's this tendon here, conjoint tendon medially, it's continuous with the rectus sheath, which should be here in this position. In this picture I have shown before, this is the fibers of the transversus abdominis and internal oblique are meeting together here in the conjoined tendon. The last muscles we have, the last important muscle from the lateral part we have is the transversus abdominis muscle, which originate from the lower 6 costal cartilage, interdigitating with the diaphragm, and also come from the lumbar fascia, from the iliac crest, and the lateral 2/3 of the inguinal ligament here, and then inserting into the xiphoid process, linea alba, and the symphysis pubis. It's supplied by the same nerve supply as the internal oblique muscle, the lower 6 thoracic nerve from T7 to T12. This is just a typing mistake. T7 to T12, iliohypogastric and ilioinguinal nerve. The aponeurosis of this muscle, okay, share in the formation of the rectus sheath. It uh, as I told you, it share in the posterior part of the rectus sheath until the arcuate line. Then the aponeurosis of this muscle lies in front of the rectus abdominis to share in the anterior part of the rectus sheath, as we mentioned before. The rectus abdominis muscle is this muscle originating from the symphysis pubis and pubic crest and pubic tubercle inferiorly to insert into the fifth, sixth, seventh costal cartilage and the xiphoid process superiorly. And this muscle is supplied by the lower six thoracic nerves from T7 to T12. From T7 to T12. The two recti muscles are separated at the midline from each other by the linea alba, and they have three tendinous intersections, okay? And these intersections give the muscles this, six-pack appearance. These intersections are found one as at the level of the xiphoid process, one at the level of the umbilicus, and one midway between the xiphoid process and the umbilicus. So one at the xiphoid process, one is midway between the xiphoid process and the umbilicus, and one at the level of the umbilicus. As mentioned before, the rectus sheath, it's a fibrous sheath covering the rectus abdominis muscle and the pyramidalis muscle if present. And this sheath contains the lower six thoracic nerve, superior inferior epigastric vessels, and lymph vessels. As we mentioned before, this sheath had three parts, or the formation of the rectus sheath is divided into three parts. One part at the or the main part is formed by the aponeurosis of the three muscles, the two oblique and the transversus abdominis muscle, and the posterior wall of this rectus sheath is not attached to the rectus abdominis muscle. There is a loose attachment between the posterior wall of the rectus sheath and the muscle, but anteriorly the sheath is firmly attached to the muscle by the tendinous intersections. As mentioned before, above the costal margin, the anterior wall is formed by the aponeurosis of the external oblique muscle, and posteriorly we have the costal cartilages only. This is above the costal margin. From the costal margin to the arcuate line, the sheath is formed anteriorly by the external oblique and the anterior lamina of the internal oblique aponeurosis, and posteriorly by the posterior lamina of the internal oblique and the transversus abdominis aponeurosis. Below the arcuate line, it's formed anteriorly by all the aponeurosis of the three muscles, and posteriorly only there is the transversalis fascia. So this is the layers of the sheath above the costal cartilage, from the costal cartilage to the arcuate line, and below the arcuate line, as I told you, the aponeurosis of all three muscles form the anterior abdominal wall. The posterior wall is of the sheath is absent. It's only the rectus muscle lying in contact with the fascia transversalis. These are some notes. The median umbilical ligament represents the remnant of the urachus. The medial umbilical ligament represent the remnants of the umbilical arteries, and the lateral umbilical ligament is the fold of peritoneum encasing the inferior epigastric vessels. The umbilical vein, after delivery of the baby, it regresses to give rise to the ligamentum teres, which is ascending from the umbilicus to the liver between the two layers of the falciform ligament of the liver. This one, of course, is discussed in short in embryology, but if you are asking about the origins of, for example, what is the origin of the median umbilical ligament? It is the remnant of the urachus. What is the origin of the medial umbilical ligament? It's the umbilical arteries. Ligamentum teres is the umbilical vein, and the lateral umbilical ligament is the fold of peritoneum made by the inferior epigastric vessels. Also from the clinical applications here regarding the anterior abdominal wall, which is now modern in the modern practice used a lot after a cesarean section to provide more anesthesia for the patient is the TAP block, the transverse abdominal spleen block. It's a local anesthetics is injected to block the nerve supply of the anterior abdominal wall from T6 to L1. It's under ultrasound guidance. We deposit local anesthetic in the plane between the internal oblique and transversus abdominis muscle to target the spinal nerves in this plane. And the question usually come in the exam, where in the tab block we deposit the local anesthetic. Just to say the answer, it's the plane between the internal oblique and transversus abdominis muscle. So here the innervation of the abdominal skin muscles and the parietal peritoneum will be interrupted. Of course, when it's originally done, it was under ultrasound guidance to know exactly the plane. Okay, but I see a lot of anesthetic doctors, anesthesia doctors now make it blind without ultrasound because they have the experience. They can know where exactly they inject the local anesthetics. Okay, but of course, it's better to be under a superficial probe ultrasound to show you the layers of the muscles to accurately inject the local anesthetics. So by this, we come to the end of the theory part. And before closing the webinar, I will show you a few questions to practice. To perform an elective lower segment cesarean section, the obstetrician makes a transverse suprapubic incision. Which of the following abdominal wall layers will not be encountered transected during this incision? Write your answer in the chat box. I got only one answer. Seems that fasting is affecting people. Yes, posterior rectus sheath, because the suprapubic incision will be below the arcuate line, so there is no posterior rectus sheath in this area. There will be only anterior rectus sheath, rectus abdominis muscle, and of course the fascia and parietal peritoneum. We move it, we cut it as well. Okay. How do you get access to the uterus without opening the parietal peritoneum? Okay. So of course, this in this suprapubic incision, there is no posterior rectus sheath, so the answer will be option B. Which structure demarcate the external iliac artery and femoral artery, or what the landmark marks where the external iliac artery becomes the femoral artery? Of course, it's the inguinal ligament. Of course, it's the inguinal ligament. Inguinal canal is strengthened posteriorly by which structure? Yes, by the conjoined tendon or the falx inguinalis. Yes, that's correct. Which structure blocks the blood supply to a lobe of small intestine at the femoral ring, causing strangulated femoral hernia? Of course, yes, it's the lacunar ligament. It's the lacunar ligament. That's correct. The pyramidalis muscle is supplied by which nerve? Yes, the pyramidalis muscle is supplied by the subcostal nerve, T12. Subcostal nerve, T12 only. Okay? Because this is small muscle, it's not found in all people, by the way. It may be found or not found. So it's supplied by subcostal nerve. The anesthesiologist wanted to anesthetize the anterior abdominal using the tap block. In this procedure, where are the nerves mostly located? Exactly, it's between the internal oblique and the transversus abdominis muscles. The blood supply to the medial part of the anterior abdominal wall below the umbilicus. Yes, it's the inferior epigastric artery, the inferior epigastric artery. There is a difficulty in extracting blood in the upper arm. The intern decided to extract from the femoral vein. What is the relation of the femoral vein to the artery and nerve from lateral to medial? From lateral to medial, it's nav, not van. Van is from medial to lateral. It's nav, yes, nerve, artery, then the vein. During laparoscopy, injury to vessel during right lateral port insertion. This vessel is a branch of which artery? Yes, this is a tricky question, okay? Because he is not asking about the artery itself. We know the artery itself is the inferior epigastric artery, yes. But he is not asking about the artery. He's saying during laparoscopy, injury to a vessel during light retinal port insertion. This vessel is a branch of which artery? Yes, we know it's the inferior epigastric, but he's not asking about the artery itself. He wants the origin of the artery. He's saying the inferior epigastric is a branch of which artery? So the answer will be external iliac artery. External iliac artery. Be careful of such type of questions, guys, in the exam, because when you rush in answering questions or you don't read the question well, you make some mistakes of this. Okay, so it's not a good thing to lose a mark of for an information you already know. Okay, so please, in the exam, you have enough time. Read the question slowly. Know exactly what the examiner wants from you. So by this, we come to the end of this webinar. I I'm really happy that you joined me today, and I hope you enjoyed the webinar and the information given in it. Of course, this webinar will be also available on our YouTube channel if you want to go through the recording again anytime. And of course, as I told you, the anterior abdominal wall part is important in the anatomy questions, so we need to cover the information given very well. Again, I wish you all the best of luck, and thank you so much for joining me. Have a nice day.